Great. Well, thank you, Shirley, for making time. Do you want to introduce yourself, maybe?
Sure, I can do that. Yes, I'm Shirley DeVere, and I am a student at CIS for the PhD program, starting year 4, Laura, with Laura, and doing my research on touch in psychotherapy. And I'm also a psychotherapist, and I teach touch work for psychotherapists, how to use safe embodied touch work in psychotherapy. And a mom for 2 kids and so on. I have some influence with my own kids.
Your teachers.
My teachers, yes. And my dog, yeah.
Yes, animals and kids.
Yeah.
Such great teachers. And you work in the Bay Area.
Yes.
And do you want to tell the students, so just so you know, you're speaking to students in the MCP program, and they,
MCP.
yes, the Masters in Counseling program.
Oh, yeah.
At CIS. And
Yes.
you're a graduate of the master's program, right?
I graduated from JFK, but I was teaching at CIS for many years until the PhD program took all my time. And I'll come back to it when I have more time.
Yeah. And the practice you're in, I read your chapter, and I'm, maybe some of the students will read it too. And you talk about using touch therapy, and also using touch therapy, ketamine assisted.
Yeah. Right? I'm not available. Can you close the door?
We keep it real here.
Yeah, this is my life.
We have lives. We all have lives.
Yeah. Say it again, Laura.
So you, in your practice, you and your research is primarily around touch, although you work with ketamine assisted therapy, correct? Yes.
Yeah, my research is on touch. I didn't want to involve ketamine at this point for my research, but I do work with ketamine with clients and touch. Yes.
So these students are just wrapping up their pharmacology class, and this week are learning about drug assisted therapies and psychedelic assisted therapies. Yeah. So
it's a big topic.
It is and so much controversy.
Yes.
And every state is different. And you're actually a really cool person to talk to about this, because you're in California, but you also do a lot of traveling. You just got back from
Israel.
And what would you say are what would you like students to know about what you know working in the field, and given the controversies that exist?
Ketamine?
Yeah.
Okay. Now my dog is here. Hold on a second. The full house. Yeah, I think that for me, ketamine work started a few years ago with one of my clients that got severely depressed after her son died for cancer, and her psychiatrist suggested ketamine work, and he knew my work, and he said, Shirley, just combine it with ketamine and just let's see how it goes. And so he started to direct me of how to work with it, and I studied ketamine, and so I kind of felt comfortable to use it. And the combination of touch work and ketamine work really was really profound. It really helped her profoundly to grieve her trauma and to have some hope for life to live. So she was my first client that I introduced ketamine work, and since then it kind of opened the door to a lot of many other clients. So basically, my clients are going to psychiatrists and they get prescription for ketamine, and they come into my office. We spend somewhere between 2 or 3 hours together, depends. And I only work with low doses. I don't do any high doses. Just I like the low doses, 100, 150, maybe 200 for people who have can tolerate that, and because I like them to still stay with me, so they're not completely gone, kind of thing. So they're still somewhere with me. They're aware of my touch. They're aware of consent. I can ask them for consent. They know what I'm doing. They know me. So I kind of feel like I like to work in that zone, in that window. So they still with me. And many times there's fear coming with taking some ketamine, and ketamine is dissociative, so they're kind of afraid of losing control and losing themselves and what will happen. And so in the beginning, I do support them with some touch, even just hand holding or putting a hand under the kidneys so they feel more regulated and less afraid. And then I kind of, once they are more relaxed and they let the ketamine be there and they can surrender to it and can let the medicine kind of do the work, I kind of stay back off and I let them see what's coming up, and then I intervene when there is a necessary. Like I kind of hear what's happening, and then I can come and again offer some touch again. I can more listen. It depends on the client. But there's 2 times that I use ketamine. I use touch with ketamine. Once in the beginning when there's fear to lose control, and then I back off and I remove the touch after they settle, and then I intervene again when they are more in the process and ready to do some more deep work. Yeah.
So when you said that you felt comfortable using ketamine, I'm imagining that some of the students might want to know, like, how did you feel comfortable? What made you feel comfortable?
Yeah, I think that there's lots of classes that people offer. There is I can recommend Polaris, for example, or Sage. Both of them are agencies or organizations that teach ketamine work. So I think that just taking classes online or in person will help to boost the confidence and what is it. And also I had a close relationship with the psychiatrist, and he guided me all the time. So I felt very, very in good hands of using it. And I also, again, kept it in low doses. No, never went more than 200. So kept it low doses.
Is that kind of standard because I know in Florida here, it doesn't seem like there's a standard, and it's used in
No, it's a new field, and there is so many different ways, and there is so many different protocols. Every psychiatrist like to use it differently, and every doctor. So there's many different ways. A lot of people do IMs with ketamine. I don't do that, of course. I only do the lozenges. Yeah, some doctors like the IMs or the 300 or so. Some people like it less, some people like it more often. I found it to be my work. One client, I did it every other week. That was that client. And for the rest, it's like even less. It's like once a month, once every 2 months or so, just as a way to help them to connect to themselves better, because ketamine is a dissociative medicine and their defenses are reducing. So we can work with what's underneath that. And that's plenty of information for a month or 2. So once they are like letting go of control, letting go of fear, and just able to surrender to it, and the work after that is to come back actually to their body, because it's a dissociative, so they kind of don't feel their body first, and then where I like to work is where they start to actually feel their body again and feel my hands, feel my presence with them. And this is where the real work starts to how I like to use it. So it's, for me, it's like coming back to the body is what I like about this medicine, because because the first part is the dissociative part, and then the second part is the coming back to the body part.
Does the dissociative piece of it, does that kind of allow them to see?
I think so. It's allow them to relax and to not be in their heads and to just relax more. Yeah.
So it almost sounds like it, like other psychedelics, it can accelerate the process in a way that it might prematurely allow for premature access to information, or what might be considered premature without a substance, like it wouldn't be accessible.
Right.
And then also widening their window of tolerance, so to speak, that
Exactly.
afterward they can be with it.
Yeah, I don't know if premature is the right word for me, but it's definitely have access to places that they're not aware of in the ordinary consciousness. And then once they're under the medicine, they can feel things or see things that they're very different. They can, a client that can feel his anger toward his father all of a sudden that he couldn't feel before. That actually very important, because all his life he's such a good boy and compliant and all that. And to feel his anger is like really important, to feel it and to come, and then coming back to feel it in his body and to embody the anger that we just discovered is a really big piece. Another client went to a very birth kind of stage, kind of like she kind of started to feel like like I saw it immediately because I'm working somatically, but you can see that she's a fetus and she's trying to give birth, like her head is stuck and she's kind of trying to give birth. So I kind of worked with that in the room with her, and she doesn't remember it. There is no memory for that, but it's in the body. So the ketamine allows the body actually to do the process that was somehow cut off or didn't complete. So that when we realize that piece, oh, there's a birth there that we need to come back to. And now we know where we need to go in our work with hands-on work, and just allow it to happen and not to be afraid, and just to say, it's okay, you're in good hands. I'm right here with you. Let your body do what it needs to do, basically.
Yeah. Like, even I think the Pat Ogden's work, it really speaks to that, because it's gotten so much popularity, and this need for the body to reconcile past experiences.
Yeah.
I have two more questions for you, Shirley. There was a quote from your chapter of your book. Can you remind me of the title of your book? Because I know this is newly released. It
just came out. It's not my book, it's edited, so I have one chapter there. It's I think it's called Psychedelic. I just got it, so let me just check for a second the name of it. Integral Psychedelic Therapy, a non-ordinary art of psychospiritual healing by Jason and Genesee and Richard Miller. They are the editors. Yes.
So that, if it's okay with you, I'm going to share the chapter with the students.
Sure. Yeah.
As an additional reading that they can choose to look at if they'd like. It's an amazing read. And I wanted to just share a quote from the section of your chapter on developmental trauma, that as I think many people know, it was rejected by the American Psychiatric Association as a diagnosis. But when you work clinically, it's very obvious that developmental trauma has long-lasting, if not lifelong, impacts on our whole being.
Exactly.
But particularly, as you were talking about with your client who had some birthing trauma, so even in utero trauma, it happens in utero, but 0 to 5 years of age, that when a child does not experience life through words and concepts, but rather they experience life through sensations, feelings, and somatic expression. And that just seems so powerful that we can only go so far through our thinking conscious minds. And at CIS, I think that I did not graduate from the master's at CIS. However, my sense is that they have a wide range of experience in different modalities of therapy that includes the body and perhaps more progressive approaches or more alternative approaches than traditional programs. I'm curious to hear from you if what you notice in the work you do with clients just using touch versus the clients you work with that you use touch and ketamine.
Yeah, I think that ketamine just joined my life just a few years ago. So it's kind of a newish 5 years ago or so. But I was using touch work like for many, many more years. And touch is a wonderful way of working and getting in touch with developmental trauma and healing developmental trauma. But sometimes it's a very slow process. It's like it takes sessions after session to listen and to be in touch and to see. Sometimes it takes 1 or 2 sessions, sometimes it takes a longer process. There's some clients that their defenses are so high and there are a lot in their head, and the ketamine is almost like accelerating the process because they're lowering the defenses because their head is not so loud anymore.
Yeah.
And they can just be more in their body.
I think one of the questions for their discussion is, of course, looking at possible risks, potential risks, and I'm curious if you have experience with risks coming up and maybe even some adverse reactions or responses from your clients and how you navigated that.
Yeah. Well, I think that because I like the fact that they first go through a psychiatrist or a doctor, so they're kind of filtered by the risk with them, and then I have a colleague to work with if there is anything. But I did have one case that she didn't feel the ketamine. She didn't feel it, and she took 100. She didn't feel it, and then the psychiatrist said, "Okay, next time you can do 200," and in 200 she didn't feel, but it just wasn't her medicine. She didn't like it and it just didn't work for her, and she's very much in her head, and it just got her. She's very small, and it just didn't work for her. And I think for her, like just doing touch work, like slowly touch work, will be a better fit for her than taking her through ketamine work. I will not do that with her again. She doesn't want to do it. So it's absolutely not for everyone.
Yeah.
But I did feel a lot of benefit for a lot of clients. This is one client that it didn't work for her. But for the rest of my client, it's a wonderful way to not be in their head and just really come back to their body in a way, and come back to the healing that happens in the body, to the inner child, to the baby, to the things that they don't even remember, of course, because there is no memory or words to it. And yeah, and for some people it's just not going to work for them, and it's okay. It's not for everyone.
I really loved that in your chapter, the client, I believe it was you, there was a client that came in and right away was very forward in her, you know, kind of aversion to touch. She's very clear that she didn't want to touch, and you didn't force, but it sounds like you really harmonized with her, and that so much came out of that.
So much. Yes. Yeah, it's a full discussion. Hold on, my battery is gonna go, so I need to plug my.
Oh, okay. Well,
um,
and I know we need to wrap up.
yes.
But I wonder, before we do, if there is anything you would like for the students to know.
Well, I think that before you consider doing ketamine work, I think you should take training, of course, in ketamine, and you should do your own work with it and see if this is the right medicine for you, if this is something that you want to offer. And if touch is the right medicine for you, also have training and be comfortable with it. A lot of times when we use ketamine, clients will go to developmental trauma, will go to younger state of consciousness or younger developmental stages in life, baby or toddler, and I'm always saying, when there's a baby in the room, you need to hold them. They need to be held, not just talk therapy, especially with ketamine. So I highly recommend learning how to use safe embodied touch if you do ketamine work. I have a lot of worry for ketamine work that is not being used with touch. Ketamine work that is being used, people are being sent with ketamine to do it in their home by themselves, and there's so many different ways in the internet, and that really scares me. And I think that even with low dose of ketamine, people can go to a very deep state and regressive states and developmental trauma states, and we just need to be there for them. And there's nothing like a hand to say, hey, I'm here with you. It's okay. You're doing okay. Everything's going to be okay. Just let it be. Let we can hold it together. Let's see what needs to happen here, and let's let the body heal. So I really appreciate the combination of both, the ketamine and the touch.
Really hear the safety precautions that you've taken,
Yes.
the protocols that you have. You're working with others, you're supported, and that.
And the consent piece, Laura, is the consent that really understand that it's okay to say no to touch. They really understand that they've been asked if it's okay that I will touch you, that there will be a lot of emphasis on consent, a real consent for touch, especially on medicine.
That sounds like there's a lot of potential for repairing
Yes.
Lost boundaries,
Right.
or
Yes.
unestablished boundaries.
Right, because we're not used to ask consent for that.
Yeah.
As a culture. Mm-hmm.
Right. Right. Well, thank you so much. You're just a wealth of knowledge and so much wisdom and love. I love the work you're doing, and I so appreciate you sharing your experience. It's so important.
Thank you.
Yeah. Yeah. All right. Well, I'll say goodbye for now. Okay.
Bye. Thanks.
Bye, sure. I'm just gonna stop the recording.